This is an education module intended to provide guidance for the patient-evaluated No Transport Required Protocol, EMS Advisory 2020-08. This educational module was developed in collaboration with the Rhode Island Department of Health Center for Emergency Medical Services, as well as the Brown Emergency Medicine Division of EMS. Just to provide some background, everybody keeps saying these are unprecedented times, right? And they are. We have never lived through anything like this. Right now, patients don't want to go to the hospital. They're legitimately scared. Some of us are probably even scared to go to work. So when you get called to a patient's house and you evaluate these patients, it's really easy just to tell them, you know what, stay home, call your doctor, and try to get tested as an outpatient. If we don't use this protocol the right way, we're going to really miss some bad things. The tendency right now is for everybody, meaning all of us and patients included, to attribute their symptoms to COVID. You know, they have shortness of breath, I must have COVID. You got nausea, vomiting, diarrhea, I must have COVID. You know, you have chest pain, maybe I have COVID. So you could see where this would lend to a problem, right? You may miss patients with pretty bad pathology, such as a heart attack, stroke, pulmonary embolism, and we may attribute these symptoms to COVID when in reality it's something else. And we'll miss it if we don't do this right. This group of patients, the patients that we are evaluating and deciding do not need further treatment or transport to the hospital, require our best assessment skills. These are patients that we're evaluating and saying it's safe for them to stay home and not be transported. This is not to be confused with a patient refusal, which is the case where we're advising a patient they should be transported to the hospital, but they are refusing against medical advice. Let's discuss some of the important requirements of this protocol. First, we have to identify the appropriate patients who meet the criteria for which this protocol applies. And those criteria are outlined in the transport and assessment tool. It's also important that we consult medical control for permission to disposition these patients as patient evaluated and no transport required. Now remember, when you're calling medical control, we should already have done a thorough assessment, including a set of vital signs, and we should be asking the physician for permission to leave the patient at home and give them instructions on home care. It is not intended to utilize medical control and ask them if they think that we should be leaving the patients at home or if they think that the protocol applies. If we're calling medical control for permission to leave the patient at home, then we've already made the decision that the patient meets the appropriate criteria, is stable and has a reassuring exam, and is safe to be managed at home, home care instructions. Now, we've already touched on patients' apprehension to be seen in a hospital. So when we evaluate some of these patients at home, there may be a tendency to coerce somebody not to go because there's sick patients in the hospital when a patient really wants to be transported. If a patient wants to go, then they should be taken, even if they meet the criteria. Patient acceptance of the stay-at-home protocol, for lack of a better term, is a requirement in order to disposition this patient as patient evaluated, no transport required. Also noteworthy is this particular protocol is not intended to replace our refusal of care and transport protocol. For example, these minor MVCs that result in a patient without injuries should still be handled with a refusal of care if they don't want to be taken to the hospital. So whenever we encounter a patient with an influenza-like illness, this patient can be considered for the patient evaluated no transport required disposition. Now, some of these influenza-like symptoms are fever, cough, sore throat, nausea, vomiting, diarrhea, muscle aches. Now, shortness of breath is also listed as one of the symptoms of an influenza-like illness. However, I will caution you regarding the chief complaint of shortness of breath. As you already know, shortness of breath can be a manifestation of some much more significant and life-threatening underlying illness, so you should take this in conjunction with other associated symptoms before you attribute shortness of breath to an influenza-like symptom. So who is appropriate to leave at home? Rather than run down the list of who fits the criteria, let's just discuss a few examples of patients that would not be appropriate to stay at home. Obviously, somebody outside of the age range would not be appropriate. If somebody is symptomatic and lives at home with another patient who is receiving chemotherapy, for example, that would place them at high risk for serious complications of COVID, so that patient should be transported. Patients that are wheelchair bound, they should be taken to the hospital. Additionally, anybody who does not have capacity to make decisions obviously would not be eligible for the stay-at-home protocol. So again, let's not forget to look for alternate diagnoses. Everybody's got COVID on the brain, so it's always the first thing that we think of, and appropriately so, but we have to remember that not everybody has it and their symptoms may be from something else. For example, when you assess a patient, you should be doing a neurologic exam to make sure that they don't have a stroke. You should assess patients that have shortness of breath for other associated symptoms of heart attack, pulmonary emboli, and other life-threatening conditions. So because of this patient's language barrier, she does not meet criteria to leave her at home. Additionally, if she wishes to refuse care and you cannot establish adequate communication with her, then she cannot refuse care and she'll have to be transported to the hospital. I put here in the slide to contact medical control to facilitate a conversation with the patient. Now, this would be excellent, however, technically may be difficult because it would require a Spanish interpreter on the other end of the phone for medical control. So in all likelihood, this patient would be transported. This patient cannot be left at home for multiple reasons. First of which, he's below the cutoff of 16 years old. Second, a respiratory rate of 40 is above the physiologic range for a 12-year-old male. So this should cue you in to potentially underlying causes that may be separate from COVID, such as asthma, pneumonia. Also, you want to look at the patient's chest to look for intercostal retractions. That is certainly a sign of underlying badness. Any kiddo that's retracting needs to come to the hospital. This patient should not stay at home. His presentation is not terribly consistent with COVID. You hear all these stories of someone that developed chest pain and suddenly died, and they were positive for COVID. That is not the majority of the types of clinical presentations that we're seeing. We're seeing cough, shortness of breath, fever. Chest pain is found in patients who are COVID positive. However, it is not the most common presenting complaint. These types of patients are the ones that really need our best assessment skills. Hello, medical control. This is COVID-1 paramedic Lauro, looking to speak to a physician for a patient evaluation. No treatment or transport required. Go ahead, paramedic Lauro. This is Dr. Young. Hello, Dr. Young. I'm on scene with a 43-year-old male. Works as an emergency physician. He's complaining of fever, cough, and a sore throat. Said he's been in contact with multiple patients who either are confirmed COVID positive or suspected COVID positive. He lives at home with his family and is capable of isolating himself. His physical exam is as following. Patient is in no distress. He has a blood pressure of 120/70 with a heart rate of 90. Respirations are 16 and regular. Pulse ox 99% on room air. He is febrile at 101.4 degrees. His lungs are clear. His abdomen is not tender. He has no focal neurologic deficits. And like I said, patient's physical exam otherwise reassuring. He is comfortable staying at home and wishes to follow up with his primary care physician. And we're just looking for permission to leave the patient at home with his home care instructions and to follow up as we have already discussed.
Paramedic Laurel, I just have one question. The patient is alert and oriented and capable of making his own decisions. Is that correct?
Yes, sir, that is correct.
All right, Paramedic Laurel, that all sounds good to me. Thank you for that thorough assessment. You can go ahead and provide the patient with your standard home care instructions. Advise the patient to contact his primary care physician as soon as possible. And I'd also advise the patient to come to the emergency department at any time for any concerns and call back 911 should his symptoms worsen. You go ahead, have yourself a safe day.
Just a couple of last minute thoughts before we finish up. I'm struggling not doing that accent anymore. So when you call medical control, make sure that you ask for a physician. Oftentimes at the receiving facility, a nurse will answer the phone to take your inbound notification, whether it's a stroke or a COVID alert. You want to ask to speak to a physician for medical control. And then, of course, you need to clearly document the physician's name, including the correct spelling. Also, we are working very hard all the time, and I want you to reach out to us at any time. If you have any questions, contact your medical director for any concerns. We're certainly all in this together. And most importantly, take care of yourself, take care of your health, both your physical health and your mental health. Exercise, talk to colleagues, talk to friends, keep yourself mentally and physically healthy. And thank you for the opportunity to give this presentation to you.